Hello and welcome to the Business Tech Insights podcast. I'm your host, Brad Nelson, and today I am joined by Anthony. Anthony, can you give us a quick introduction?
Hi, I'm Anthony Distanzeri. I'm the CEO of Reno Radiological Associates. We are a very large regional independent physician practice in radiology in the Reno, Nevada area. And I've been working with them for about a decade, and I have a pretty broad background in business before that, in accounting and finance and that sort of.
Very cool. What can you tell us a bit about your background? What led you to working here?
Well, it's funny. Pretty much everybody who works in my industry and my space kind of fell backwards into it. I don't think there's any training program for this, but me personally, the folks who recruited me into this role that eventually led to me becoming CEO, the f- I joined a revenue cycle management company, which is sort of the folks who collect money for doctors, and I joined what's called their practice management division. And so instead of specifically focusing on the revenue collection side, we kind of managed everything else, like sort of a rent a CEO, if you will. And those folks were looking for accountants with personalities, pretty much knowing that they would never find or rarely find people who had done exactly this before. And so I had a pretty broad background, like I said, in business and finance. I have a master's in accounting, and I worked for sort of big four accounting firms, all the way through sort of Fortune 500 financial reporting. Eventually, I became a capital markets director for a very large private developer, and so I had a bunch of different skills that I'd built through my time, my career, and they were looking for somebody who could help lead physician practices and help to manage sort of the day to day operations. And so I joined that firm and worked there for about 6 years before I got hired full time as CEO of an on site practice.
Very cool. Very cool. Now, I know before we started recording and stuff, you talked a bit about the importance of independent practices. And why is it important that these independent practices remain independent and aren't gobbled up by big kind of corporate hospitals and that sort of thing?
Well, I think it all boils down to incentives and pressures, right? If you think about the incentives and pressures around running a physician practice and being a physician, uh, first and foremost, what do physicians really care about? They care about their own quality of life, their family, of course. They care about their patients and their local community. And those are sort of the primary things that physicians really care about, right? Um, and they want to practice the way they've been trained in the manner that most efficiently allows them to do what the work they really have trained their in some instances 15 plus years or more for, to really treat patients in their community. And being an independent practice allows them the agency, the facility to really do two things. One, manage their own economics, their business in a way that optimizes their own personal situation, and then treat the patients that they're treating in a way that, if you're running the business, really treat it in the way that you get to make all, obviously you have partnerships and other stuff, but really optimally care for the patients in the way that you want to. It gives you a little bit more agency. It gives you a little bit more freedom of your own circumstances. And so you just think about it in your own life. I mean, if you're an employee of somebody else's business, or if you're running your own business, obviously those are two separate things. And of course, even if you're running your own business, that doesn't mean that you're not, bound by certain rules and expectations or other stuff. I mean, that's part of corporate life, but it gives you so much more agency when you are your own independent practice. And the other thing that's really important about it is the net profit from that business isn't going to somebody else. It's going to the physicians. And as you may know, we're in a position where physicians are in a huge crisis of staffing, limited staffing, and sort of demand specifically in radiology that's really burgeoning, with sort of boomer you know generation getting older and requiring more health services and being the largest demographic, coupled with the fact that so many of them are actually physicians as well who are retiring, and the fact that the government sort of supports and the training programs, and they're not in the best of financial condition. So there's a lot of confluence of factors that's creating this really big pent up demand, coupled with this shortage of physicians. And so that part of what I do is try to help my physicians be in the best opportunity to for their own, for their families, and to treat their physician their patients locally. That's sort of my role, is to help them do that as best I can.
Yeah. So now, in the practice that you're CEO of, are there multiple physicians, and how exactly does that work? Are they business partners, or that's how it is?
Yeah,
Okay.
pretty much. So we're a professional services corporation that, S corp basically, and so it, like I was saying before, with respect to independent practice, you want physicians to own the business, to take charge of it, to sort of manage it in the way that, they, be a part of the business, if you will, not, like, and that's not for everybody. There are certainly roles for part-time folks, for people who just want to be employees. Like there's part of that in our practice, and generally speaking, but a lot of physicians derive, it because it's a bigger commitment, right? If you own
Hmm.
the business, not only are you working as a physician, you're also, have to spend at least some time managing and operating the business itself, which is an additional commitment. But for that, you also derive the benefits from that of sort of owning the business, and the profit really the net result in profit ultimately goes to the shareholders. And so, yes, our physicians own and operate the business. They kind of get together and monthly, if not more often, and kind of run and operate it that way. They all have equal shares, basically, unless there's some transitory part where you're a junior partner. For the most part, they're all equal. And so you've got this very large democratic type group. We have about 25 physicians, soon to be 6 nurse practitioners. We'll be 26 physicians soon. And so we're growing. But basically, there's a subset of those physicians who are pretty much exclusively all full-time on-site, have more often than not been with the group for quite a long time, and are really invested in and continuing to make the group business successful, and sort of on the boots on the ground, helping to manage the business. Um, the nature of our business these days is, Telerad has allowed people to work remotely from anywhere they want to, and still read from and to any location, pretty much in the domestic US. And so that complicates things a little bit. But there's so much on-site requirement as well it's much better if partners tend to be local still.
Yeah. So, how much can they do remotely? Because I would assume that a lot of the treatments have to be done in a facility, but maybe is it like the consults are done remotely, or?
Yeah, for the most part, reading diagnostic scans is done remotely. But I will say, so we have 3 subsets of physicians in our group. Main subsets: we have diagnostic folks, we have interventional radiologists, and then we have neurointerventional radiologists. And
Hmm.
2 of those are procedural heavy, right? And obviously, you have to be in hospital to do the procedures. And I will also say that diagnostic physicians also do procedures as well. They typically do ones that are less intensive, but it definitely helps to have folks on site in case one is needed, especially if they're taking call, at night, and a procedure is needed or something like that. And so they all, to a certain extent, who are the on-site folks tend to do more procedures. You can sit entirely remotely in another state and read diagnostic scans, take phone calls. Um, you could do consults, but consults typically go with procedures. And so it's less common to do consults remotely. It really
Hmm.
is mostly about interpreting images
Hmm.
remotely. That's the bulk of the work.
And how do you? Because I mean, you guys are held to HIPAA compliance standards.
Yes.
How do you remain compliant, but through all this like remote work and keeping all your data safe?
Great question. We are partnered with a fantastic health organization, a local health organization called Renown Health. We're the exclusive radiology provider for a physician services provider for Renown Health, and so they actually they do sort of they're the facility technology sort of package, if you will.
Yeah.
They have all, they have the hospitals with the staff and the IT resources and the support and the systems and networks and such. And we provide the physicians and the folks who are working in, the professional nurse practitioners and physicians who are working in the hospital. And so through that partnership, they really provide a lot of the technological aspects, and they do a really good job of that. And we work with them to optimize the configuration. Obviously, our rads are the ones who are sitting at workstations, actually working, producing the work, and so it's a collaborative and ongoing process where we engage with them regularly to make sure that the technology is accomplishing what we all expect it to. And they're sort of going out to market with us and making sure that we've got sort of the latest and greatest to provide the best care to patients. And that's kind of how the relationship is operating in our space. That's not always the case with every group. I've managed groups that had a lot of groups that manage multiple health systems. We don't. Will have their own IT systems, servers,
Mhm.
workstations and all that. And some of that's group fund, sometimes that's group funded. Sometimes the various hospitals will give different workstations. It depends setup to setup. A lot of groups will actually own and operate their own imaging centers, which we do not. And so that's sort of soup to nuts, this freestanding imaging center where they buy and, provide all the technology for their own physicians. And so it's funny. You can put two groups that, on paper you would think are pretty similar in the space, and the way they operate and the personalities involved and everything else can be quite different group to group. I've managed or been involved in managing 10 different physician groups in my career. And so I've seen a pretty wide variety of practice in what you would otherwise consider a fairly narrow scope of, say 10 to 20, 10 to 30 physicians doing, subspecialized work in the same subspecialty. And so it's interesting that there's so much variety even within sort of a narrow scope.
Yeah. Yeah, definitely. So then your physicians actually like go to a hospital and use their equipment and stuff there, or do you have your own facility?
Both, actually. So
Okay.
in this day and age, they have remote reading workstations that folks who, well, assuming you have the internet connection for it, because there are basic requirements. Like if you live on the side of a mountain with no internet, you obviously can't do that. But although Skylink is a viable path, you usually want at least two internet connections for a backup in case one goes down. So if you're going to work from home, which is typically what we see, but yeah, we have shifts that are done exclusively from home. We have people that 100% do the, shifts from home, but a lot of our shifts are also in hospitals. So, it's sort of a combination and depending on, your circumstances and the group's needs, we sort of figure out what the optimal configuration for each person might be.
Yeah, yeah. It's interesting you mentioned using two internet service providers because, I'm in rural Montana and we see that all the time here. We're working on a project, um, a big house, and they are getting two internet service providers, going to their house because for what they do, they need that reliable, um, they need the internet to be reliable. So they have Starlink and then another more local ISP,
Right.
and we're setting them up to where it'll fail over to one or the other. And
Yep, with
but
backup power and all that good stuff. Yep.
oh yeah, yeah, and it's
You
yeah,
gotta think, I mean, really, these people are covering the ERs around the country, right? And so the people that are working remotely now, their service is critical. If it goes down, you need fail safes because they're on call. They're not on call, but they're on, and if all goes to hell, somebody eventually needs to drive into the hospital, but that's obviously a pretty big drain on the group that, or the health system or whoever's employing those rads if you've got remote people without reliable internet connections that are going down more often than not because somebody's ultimately going to have to go to the hospital and serve the ER. You can't leave the ER down because your internet went out. So it's something that we certainly take seriously. Our industry does as a whole, and you've got to plan for that.
yeah, yeah. So what kind of what kind of services and treatments and stuff do you guys offer to your clients?
Well, it's funny if you think about the total volume of work or patients that go through a health system. I don't know what the percentage is of patients who get imaging of some kind alone, just imaging, right?
Okay.
But I mean, think about uh, pretty much anybody that goes through an ER, for the most part, unless they've cut their pinky or something like, and
Yeah.
you're getting imaging, right? I mean, if you don't know what's wrong with somebody, if they come in unconscious, that you're ordering imaging. If you hurt your foot, they're going to order an X-ray. If whatever it is, right? So I don't know if it's 90 something percent of the population that ultimately, and you're often sick patients will get imaging repeatedly, right? And so there's a pretty wide percentage of folks that will, in some form or fashion, touch radiology, and radiology is obviously working in concert with all the other specialties in the hospital, whether it's mammography, oncology, pediatrics, and anybody to really kind of treat whatever patient with whatever relevant condition. And so um, the scope is so broad. It's I mean, I don't know. Pathology is similar, where there's a pretty wide variety of what they could encounter, but I'm not sure that anybody has much broader of a scope than radiology because they literally need to know every part of the body. I mean, they
Yeah. Yeah.
it's they read everything. There's not and there are certainly people who specialize. Like we have musculoskeletal or neuro people who, if there's a complex case, we try to get the right scans to the specialist. But generally, especially if you come in overnight, I mean, whoever's working that night is going to read, going to do the first read on a stroke patient or whomever that is, right? So they all generally read far more broadly and work in more areas than most physicians do, and so the scope is pretty broad. Maybe that's a more generalized way to respond to answer that question.
No, no, I get what you mean. So I want to ask you, this is kind of a hot topic right now, and we can get super technical or philosophical or however you want to handle this, but what do you think about AI in general, and how is AI affecting your industry?
Sure. As you might expect, yeah, it's in the news, it's everywhere. We are working with AI. We've been doing it for some time now. Um, I like to AI as a tool, right? And you kind of, in order to look forward, sometimes you look backward. I like to explain it a couple different ways. First off, um, there were radiologists that were working before PACS was invented. PACS is basically the imaging software suite that allows you to see images on a computer. They used to hang films with lights behind it and try to deduce from those images what was going on. And they would take several films a day, but it was image by image, putting the lights up, like that kind of a thing. That existed before PACS, right? And after PACS, it made reading radiology much more efficient. And there were plenty of people that said, "Oh well, PACS will be the end of radiology. Radio. We don't need any radiologists because everybody will be able to see their images digitally. And why would you need radiologists after that?" Well, come to find out, now we need radiologists more than ever. We have this, the opposite has been true. And so, and PACS was a tool. PACS was a tool that made reading images more efficient, right?
Hmm.
In the same vein, there will be radiologists working before AI, and then there will be radiologists working after AI, using AI as a tool to make themselves more efficient. Uh, I like to also describe it this way. Uh, that game Where's Waldo?
Yeah.
AI is really good at Where's Waldo. It's way better than human at, if it knows exactly what it's looking for, it's very good at finding that thing, right?
Hmm.
Now, they're not necessarily looking and finding any one specific thing when you're looking at images, but if you train enough times to find that one thing or several things, you'll probably be pretty good at least identifying, I think that thing is there, right? So AI
Yeah.
is great at Where's Waldo. It's also really horrible at that other children's game where, it's that picture, that goofy picture where the dog is sitting on top of the house wearing a flower pot on its head. It can't tell you the first thing for why there's a giant wrench on the doghouse, right? It has no idea because it has no cognition, right? It just recognizes patterns, right? And that's
Sure.
a pattern that makes no sense. And so could it generally try to identify that picture and figure out, like it's just really bad at that, right? And so two children's games where, one it excels at, one it's terrible at, right? And so that kind of in a nutshell tells you a lot about how we use AI as a tool, right? So we use it as a detection software to try to bring people's attention to say, hey, we think more often than not there might be an issue here. We need somebody that has a medical license and insurance, among other things, to look at this image and say, oh yeah, that in fact is that thing, or it's another thing. And it will sometimes they'll give feedback to the AI to say, oh yeah, you were right, or no, you were wrong, and it will, in theory, hopefully get smarter.
Yeah.
It's not even operating at this point. So there's, in radiology training, there's like medical school, then there's residency, then there's fellowship, and then there's, like sort of practice, right? It's not even operating really at the level of a resident yet.
Mm.
Uh, with time and training, maybe it'll get smart enough to be operating as a resident. And what a resident does in a training program is they do a lot of the grunt work so that the folks who are, the senior people in that program can focus on the more important, critical, difficult cases, right? And so maybe we'll eventually get to the level of a fellow where, it's really kind of capable of doing a lot more, and folks will really be able to specialize more. But with the amount of demand they have, honestly, we're, as an industry, hoping that radiology allows us to keep our head above water, given the spike in demand and sort of where radiology staffing is trending these days. And so we need those efficiency gains with technology just to be able to produce the amount of work that's required. And I will tell you, I don't know if I've ever, like, I've seen people a lot of work hard in different industries. I don't know that I've ever seen anybody work harder than radiologists having to read, on a night shift, like 3 a.m., 2 a.m. every single night, cranking out, hundreds of studies to basically cover an entire health system's worth of volume. And obviously at night it's less, but just generally speaking, the amount of volume that these guys are producing to interpret images, and this is sort of, this is life and death stuff, right? They're putting their license
Hmm.
on the line every single time they interpret an image to say, hey, this person has this or that, or you need to check into this. I mean, like, they're part of the care delivery system, right? They're not, they talk to the surgeons and they talk to, the primary care doctors, and, it's an integrated service where we're all kind of working together as a larger team to help patients in the best way possible. But it's a pretty long-winded answer of saying AI is going to be a tool, I think, at least for the foreseeable future. Uh,
Yeah.
and, and without it, I'm not sure we could really accomplish our mission the way that we ought to.
Yeah. So you think overall it's making the jobs of the physicians a lot easier. It's kind of helping. Uh,
Let me stop you there, because I
okay.
will say it is starting to make the lives of physicians easier. In
Okay.
the early days of AI, it was actually more of a burden than a
Mm.
help, because you had to give it so much feedback and it was bad. And so a lot of radiologists would have complained, in the early days, that like, why the hell am I even using the stupid thing? Like, it's wasting so much more of my time when I could be treating patients, and instead I'm focused on training this thing that's not really helping me that much, right? And
Yeah.
so we've
Yeah.
seen a progression of it moving toward being helpful. And I think now, in certain specific tasks, right?
Right.
It's task oriented but quite specific, right? So I think people will say, oh well, we have this stroke detection module that when a patient comes in, gets a CT scan, can identify it more often than not. We think that might be a stroke, right? But
Mm.
it's not looking at a patient and be like, oh, what can this patient possibly have? All of these, all of these modules are task specific, and you have to get FDA clearance, which is a government regulatory, like the government
Yeah.
regulatory side of this thing too. Like, they don't just let the AI do whatever the hell it wants, right? And
Right.
this thing
Right.
is highly regulated. Healthcare as an industry is usually at least 20 years behind everybody else. So that hopefully we can learn the lessons from, what happened, disaster areas in every other industry, and kind of apply it so we don't retread the same stuff, right? I think that's, we're trying, but it's limited, right? It's limited for that reason, for patient safety and other reasons. Technology in healthcare always follows behind, does not lead the curve, because you don't want to be the first patient in the first AI case. Like that. You just think
Yeah.
of the implications from that. You've really got to be careful with that.
Yeah. Do you think, since you've seen improvement, do you think at some point it could get to the point of replacing physicians? Like, we're talking way in the future.
Well, I will tell you that right now, if you're in a third world country, having an AI program is better than having nothing. And so it depends on the circumstances and depends on what you're talking about, right? Um, yes, and if you're if you have a portable X-ray and you can send the scans to somewhere, and if you're sitting in Africa or somewhere and you don't have access to in any kind of radiologist, an AI would read it and at least tell you more likely than not what you're dealing with as a doctor in a place without a facility. That's great, right? I mean, and so I mean, I would argue that in some respects they're probably doing that on a limited basis right now. But the reality is there's a couple of components. I mean, first off, like I said, AI is good at doing certain things. It's very bad at doing other things. It's wrong. And you don't you need somebody. You want humans to sit there and verify the information to make sure that what you're actually saying is accurate, right? And so, in a place with resources and facilities that like you really have to get it right. Uh, not that not that it shouldn't be right for everybody, but if you really don't have the infrastructure at all to treat people, it's better than nothing, right?
Right.
Yes, it will make us more efficient. And I don't know if it'll ever get. I mean, like you hear like Eon and some of these folks saying, "Oh, like don't go to medical school." Well, they said that they said AI. The New York I famously printed. I think in the beginning part of the millennium, someone made this famous prediction that like by 2016 you wouldn't need radiologists, so nobody should go into radiology, be a radiologist. And lo and behold, they were wrong. You have this massive, too many people listen to that advice, and now you have a big shortage of radiologists. So um, I don't like I said, I think it will eventually get to the point where it'll allow people to do a lot more work per person and be more efficient with their time.
Yeah.
Do I think it's going to full on replace people? I mean, I can't predict what's going to happen in 20 plus years. I know in the next 5 to 10, it probably will not. Beyond that, I mean, hell, they're saying that they can do surgery better than surgeons potentially in the future. I mean, so where does that leave you if you're going into medicine? I mean, I don't. There are things you can kind of see, predict. I know what the circumstances we're dealing with right now, but in 30 years, I have no idea what AI is going to be doing.
Yeah. Well, there is something to be said about having a bedside manner, though, and I don't
Yes.
know that a computer can have that. A computer can't empathize with
No.
a patient
No.
or anybody else. And so I I wonder if, like you said, it's going to make jobs way easier, make people's time more efficient, but I don't know that it's ever going to make that human interaction obsolete. At least I
No.
sure hope not.
I don't think so. I mean, I think you're always going to have physician centered patient care in one form or other. Um, We'll see. But
Yeah.
I agree with you. I mean, like, calling a patient and telling them they have cancer is not something you want probably to be done automatic message. I mean, I get mad when I hear the phone tree for the 1-800 number, like, for the 7 numbers. Like, I just wanna talk to somebody, right? I mean, like, that's just on the phone. I mean, like, imagine, like, the worst case situation in your life. You really I think, like you said, human connection and human interaction is important, and I think it always will be.
Could you imagine that, getting an automated phone call saying like, "Hey, this is an automated call from XYZ hospital. You have cancer. Bye."
I'm sure people will be recording it and putting it on the internet. So, I
Oh
mean,
yeah. Oh yeah.
please look go to this facility, whatever one it is, because they're doing this, right? I mean, it sounds like pretty bad marketing, but I mean, I'm not going to say, like I said, if you have access to literally no resources, maybe you accept that as better than nothing. But um, I don't see it happening in the foreseeable future.
Yeah. It's interesting you mentioned, getting on the phone and having to go through menus and all that kind of stuff. We deal with that a lot in the IT and technology spaces. Um, a lot of tier one kind of help desk people are being replaced by automation, and it's one of those double-edged swords. It's like it's cheaper
Yes.
and it's more efficient and stuff as far as business goes, but you lose that human connection. And
And just really, people want to talk to other humans that are competent and know what they're talking about, right?
yeah, yeah,
Like, phone tree is objectively worse than someone saying, "Hi, how can I help you?" Right? I mean, like,
yeah.
that's just it's just an objective fact. Like, no, like,
Oh,
and
yeah.
being able to help you, right? I mean, like, so I mean the other thing I wanted to mention, industry wide in radiology, generally speaking, this is an interesting case. It's been widely observed that radiologists actually spend only about 15% of their time actually interpreting images.
Really?
So you would think your radiologist, your time is spent doing this. How much of your time, on average, right? That's not our group or anything specific.
Sure.
And so the goal, with the advent of EMRs and like some like all of the technology, and the hindrances that some of the technology brings, because it doesn't always play nice with each other. It likes to disconnect. It likes to have all this other, these issues. It's all complicated interactive software where it wasn't built in one ecosystem. So you're having multiple systems interact with each other and different technologies. Technology is often a problem, right? And so it can be a hindrance. And just like the act, and so the actual physical, act of interpreting images, which you would think, they would spend all, they the goal is to try to get them to spend more of their time doing the thing that they're most beneficially interacting with patients to do, right? Um, to go make that 15% be 30 or 40%, right? I mean, that's sort of the goal and the benefit of all the technology, be it AI or anything else. And
Yeah.
so it's kind of interesting to, when you think about, like, there have been studies that have, done on that. And there's not that I think this is necessarily, the best practice or whatever. But there is a radiologist now who, and I've heard about this, where he uses multiple medical scribes, uh, and like to write all the information, and all he has like all these different people to try to figure out what the limit of efficiency can be, and he can read hundreds of scans an hour when way more than a typical radiologist would read, because he constantly has other people plus technology making him more efficient. But the question then becomes like, well, is that really good for patients to be reading that fast and that sort of thing? And so,
Yeah.
what's the right way to do it, in a safe way? Because radiologists, like, nationally, right, aren't always right. You're interpreting images. Um, they say if you look at a head CT from 1995, it's a wonder they were able to read anything, because the resolution was so crappy, relative to where we are today, that they couldn't, they were just kind of guessing sometimes. And as the technology gets better, you can see more stuff, and but there's always gray area. You're not really, like, it's some measure of art mixed with science, right? You do the best you can to interpret the image that you're seeing, and is the image quality as good as it could be, or like, sometimes technology isn't where it ought to be. Like, different scanners have different different it's not all just sort of one size fits all, right? Different modalities are better than others for certain things, and sometimes the outside imaging you get that from other facilities isn't the best. Either the technologist who was taking the image wasn't, as good, or the scanner had an issue or whatever, and you're still, you're doing the best you can with the information you have to help that patient, right? So
Yeah.
there's a national miss rate of, I don't know what the, several percent, and they're not always right 100% of the time. I mean, like, that's just the reality in dealing with, and there was a study that was done that something after, like, if you read more than 4 scans an hour, your miss rate starts to climb.
Wow.
The hell reads 4 scans an hour, right? Nobody. And they did this in Japan, I think. Um, our physicians read, every physician in the country that's doing radiology reads way more than 4 scans an hour. Um, and yeah, if you had time for a coffee break and whatever, go back to one image, that's fine. But you're not treating that many patients, and we have a lot of patients that go through a health system. So there's a matter of trying to treat as many patients as you can, but also doing it in a safe and efficient way. And that's always going to be a balance. We're trying to improve the metrics around that in a positive way using technology and other factors.
Hmm. Hmm. Well, I know. I mean, technology has to have feedback to mature. And so, you know, unfortunately, it's one of those things I think, in my opinion, that even though things aren't ideal, continuing to use them is what's going to improve them. I mean, that's what you see with the CT scans, I'm sure. You know, like you said, back in the 90s it was terrible, and now it's better. I'm sure it could be even better, 30 years in the future. It's going to be something we probably can't even fathom how good it's going to be.
Right.
But what kind of other technology do you guys leverage to serve your customers the best you can?
Um, well, I mean, most of our when you're talking about serving patients, right? Most of our time is spent, either procedurally in procedures, so all the technology around, you know, and there's all kinds of stuff, like sometimes they're using contrast in connection with a procedure to try to identify what, you know, where the needle ought to go and that sort of thing, or the
Sure.
or the catheter. Um, there's a whole wide range of technology, but a lot it breaks mostly down into two categories of, whether it's MRI, CT, X-ray, ultrasound, any variety, all the modalities that fluoroscopy, all the modalities that are used to interpret, to create images that somebody can interpret in a way that, helps them to know more about a patient's condition, right? And then it's sort of all the technology around procedures and making sure that the procedure that you're trying to do is more successful, right? So those are the two main avenues. I mean, I obviously, as a non-physician, I'm the only non-physician in our practice, use just sort of the more basic stuff, like you use your Microsoft Outlook and Excel and pivot tables and all that kind of stuff. Adobe. My life is a lot more limited in terms of technology than theirs is, certainly, and that's, as I said, enabled in partnership with the hospital. We have some really fantastic cutting edge technology that helps us to treat patients in our region. And to our hospital's credit, they really have stepped up and provided some fantastic tools. Ours is a flagship hospital for AI Doc, which is an entire software suite around which they develop AI modules, and we have some of the latest AI detection modules that are available, which are, we actually are getting, we have a dictation software that automatically generates impressions based on the impression, so you have like, basically, like, you dictate the findings and the impressions sort of underneath. It auto generates that. In the future, they're working toward giving us this ability to really just talk into the box, and then AI will develop the totality of the imaging report just based, it'll put it, instead of having to type stuff and click stuff, it just knows where it's supposed to go based on what all the reports you've done in the past. And you're basically checking instead of having to input manually, which is another efficiency time saver. There are so many different technologies that we use to do what we do, but that primarily falls into, either making a radiologist more efficient, or just interpreting images generally. That's kind of the scope.
Yeah, yeah. Now, with the hospital giving you some of the more cutting edge with the AI software you're talking about, and probably most of the big expensive equipment, I would assume. What kind of technology do you guys have in your own office? Just workstations, or do you have
Well,
any cool machines in your own office?
that's the funny thing. So a lot of, like I said, independent physician practice can be widely divergent practice to practice in groups that you would otherwise consider pretty similar. And so
Mhm.
I I've worked in groups that have offices with equipment and servers and technology. Our group, one of the things we really try to do is we try. I've helped to work and make this group as efficient economically as possible, and so I'm really the primary administrator. I'm the only non-clinical physician in our practice, and I work with our leadership in the group to sort of administer, the totality of the business. And so I actually work. I live 5 minutes from our hospital, and and I work out of my house, and so
Yeah.
I've got a monitor, a printer, and we keep it pretty light. And really a lot of what I'm trying to do is maximize the return to our shareholders, right? I mean, they got into medicine, and it's a very expensive thing to do. They go half a million or more in debt just to sort of get to a place where they can really start working,
Yeah.
which is kind of crazy when you think about it. And so we try to get them back in positive territory as fast as possible. One of the easiest ways to do that, of course, is to keep your overhead low. So if you don't have huge staff, you don't have office, you don't have all the other stuff, you can return more return more profit back to shareholders. And so we're pretty proud of our footprint and the way that we operate. And so that's just this particular group. But I mean, there are all different kinds of groups and operating in different ways out there. So if you own an imaging center, for example, it's way more capital intensive. I mean, you have multiple imaging center facilities, and you've got the imaging equipment itself, MRs and CTs and stuff that are millions of dollars, in many cases, just to install one of those things. It's a much different animal. But our business is, yeah, our footprint is super light.
Yeah. Okay. Okay. So then is it accurate to say that the physicians are either working at the hospital or working from a home office?
Yeah,
Okay.
working from a home workstation. So we have and we have physicians as far and wide as we've got someone working from Florida, we've got someone working from Texas, Colorado, New Jersey, and so we have physicians sort of across the country. And part of what that does is allows us to time shift our schedules in a way that makes sure that people are, because we there are always multiple physicians in our practice working at some point, day or night, holiday. They're these guys are the real superheroes, really. I mean, and
Mhm.
and I'm doing my best to make sure that they guys and gals are able to treat patients as best they can. That's kind of my role, but they're working constantly 24/7. There's always somebody, for example, on stroke call. If there's a stroke that comes in anywhere around our region, they're coming in. Our interventionalists are on call. We have an interventionalist on call at the main hospital every single day, holiday of the year, all the time. If there's, they and stroke folks, uh, it's easy to say what diagnostic people do. They kind of interpret images. It's easier to say what neurointerventionalists do. They typically deal with strokes, aneurysm, that sort of thing. And then people kind of get lost with interventional radiology. Um, Without interventional radiology, hospitals wouldn't have an oncology program. They wouldn't have a trauma program. And these are, like really big factors. And they do a lot of procedures in the background, especially, like that really allow those programs to operate. And so without a good IR program, your hospital doesn't have that. And those are obviously big, money making operations from the hospital from a revenue perspective, but it allows you to treat a whole lot more patients in a whole lot more ways. Our hospital operates as though we're a level one trauma center. And so we get a lot of patients flown in. Anything that happens in Tahoe, which is only 30 minutes from us, closer by helicopter, gets flown in. So, I mean, like there's a lot. And if you think about geographically speaking, Reno, a lot of people don't even know where Reno is. It's kind of a weird phenomenon in the national conscious. Like nobody knows where it is, right? It's west of LA and it's north of San Francisco, but we have a catchment basin. There's only two big cities in all of Nevada. You got Vegas, which is 8 hours away from us, and then
Uh-huh.
you've got Reno, and then you've got Salt Lake, which is 7 hours east, and you have Sacramento, which is over the mountains a few hours west. And so everything around that space probably, like if anything's serious enough, it gets flown into us. And so that's the nature. And you need to have the competent staff in place to have a trauma and a stroke program. And that's, we're proud to have some really exceptionally good programs in our area. I think, especially for a population of about a 500,000 people, which is what our area is. A lot of cities that size do not have nearly the capability that our health system does, or the some specialization. And so
Mhm.
that it's something that people in our region probably aren't even always aware of. But when you need it, it's nice to have it so that if you have a stroke, you don't have to get flown to Stanford.
Yeah. Yeah. Cool.
Yeah.
Well, that's all that's just about all we have time for. Anthony, what's one thing that you'd like to leave our audience with?
Well, I guess I I I would say appreciate your doctors and fight for them because unfortunately we don't have as much as many of them as we used to. And the I would tell you that the increasing in my view, the increasing corporatization of medicine is kind of what I do with advocacy, right? I go down, I try to make our lawmakers and other people aware of the importance and sort of the dire circumstances that as an industry we're working in. It's not a pretty picture. You have private equity, which is sort of, if you think about the incentives and pressures associated with running a physician practice, their incentives and pressures tend to be generating fees for themselves and taking as much of the pie as they can, and then that leaves physicians and patients, not necessarily of the better. Um, Healthcare is simple. It's hugely complex, but at the end of the day, I believe it's fundamentally simple. If you do right by patients and you do right by doctors, you're going to be a whole lot better off. And if you're not, or ideally both, right?
Yeah,
But
yeah,
if you're focusing on those, those folks and doing right by those two parties, I think that's the best you can. But just understand that there are a lot of people, like at insurance. I mean, like, I think United Healthcare last year made like $22 billion. I don't know if it was the year before. They're taking all this profit out of the healthcare system, right? It's
hmm
not going to doctors. It's certainly not going to patients. They're, and think about just nationally how the health market works. I mean, it that's why it's important to support doctors and policies that benefit doctors. Uh, and we need a whole lot more of them. We need to appreciate these people because they are the quiet superheroes of our time, like that are really treating patients. They're 24/7 and helping people. And people, sometimes say, "Oh, well, those doctors they make so much money." Well, they're working Thanksgiving night.
yeah,
They're there Christmas Eve. If you fall and break your arm, who's gonna treat it? Those people are. So, I
yeah,
mean, and they've also incurred a $500,000 of debt or more to be able to be there for you on Christmas Eve. And
yeah.
so when you ask like, well, should the health insurance company make that much money? Should the private equity firm be making that much money? Or should be the guy who has 3 kids at home on Christmas morning, who has to get up and take call to treat your loved one, should they be? I mean, like the, the doc, if you look at, I know this is broader than you probably thought, but like just look at the total amount of healthcare spend that goes to physicians. I don't even think it's in the 20s of
Really?
percentile.
Wow. Wow.
Like, just look at where the money goes and just try to, advocate on behalf of people who are really fundamentally there to help you. And do hospitals do that as well? Yes. Do I have my thoughts about private equity owning hospitals and owning physician practices, like, and the conflicts of interest that are within our system that are just that would only exist because they have so much money for lobbying, which is all true. There are, but ultimately advocate for your physicians and appreciate the hell out of them because we're lucky to have them. We're lucky they do what they do, and that's that's what I've experienced in my career. I'm passionate about physician advocacy because I know how hard these guys work and I know how many lives they save and I know how important they are and I know like how much dire condition more we'd be if more of them decided to say, "You know what? This is too much. I'm done with this." Which many of them are financially successful enough that they could do. And
Yeah,
so it's
yeah.
a credit to them to have the commitment they do, to do what they do day in and day out to help us as a community. And I think we really need to do right by them and do right by patients. And I see way too much of people doing, like doing what's best for other parties that are not physicians and patients. And it just drives me nuts. So that's my soapbox.
All right. Thank you again, Anthony, for joining us today. Where can people find you?
You can find me on LinkedIn. I've got a pretty unique name, Anthony Distanzeri. And if you're a physician who's interested in learning more about what we do and working with our group, I'd welcome conversations or other folks that are interested in radiology. generally, or have other questions about physician practice management and other stuff, please find me on LinkedIn. I'm readily available there, and I do my best to try to help folks. I tell people that I'm in the business of helping physicians to make better decisions, whether that's folks in residency and medical school aspiring to be specialists, or folks that are currently in practice and looking for other opportunities. So please, I'd be happy to help. Just reach out, and you'll find me there.
All right. All right. Well, thanks for joining us today, Anthony. And thank you all for listening. You can find this podcast on YouTube and Spotify, and we'll see you in the next one.
Thank you.